Hi, my name is Michael and I'm your guest lecturer on a session on perioperative nursing. So I've made lots of small segments hoping to break things down and want to look at how we take care of patient safety and patient-centered care. So that involves checklist, but also infection control and VTE risks and so forth. There's a small section also on sustainability, and that includes recycling. Then I sort of give you the description of the different roles in perioperative nursing, and there's three main different roles, and I've used the ACORN standards for that with their role description, and ACORN is the Australian College of Operating Room Nurses. And then lastly, I present a case with nursing considerations relevant to an obstetric patient who is to undergo a lower uterine segment cesarean section. So hopefully, if you study midwifery as well, that will make it a bit more interesting to you. All right, so I hope you enjoy the sessions. I've left my contact details with Alan Dyke. So if you have any questions, I'm more than happy to answer them to you. I hope you enjoy perioperative nursing and come back to us on the placement and even on a grad program, even better. All right, thank you. Bye. So this last part of the introduction, I just briefly want to mention you the fact that perioperative nurses, and all nurses really, have a role as being a patient advocate. So nurses are stewards and guardians of patients during their entire perioperative journey. We tirelessly do our utmost to prepare our patients before starting surgery without missing a beat. We speak up for their safety. We do our utmost to prevent patients from acquiring infections. We know of their anxiety and uncertainty about the surgical process and provide cultural safe support, for example with using interpreters. We use our expertise to prevent any deterioration, and we work with the medical teams to enhance our patients' recoveries. Now let's have a look at the patient's journey, and this is a good framework so you can understand the flow of the lectures. So if a patient is diagnosed with disease, they need to be informed by a medical doctor in the specialty of their injury or disease, need to be informed on what their options are. So the options of care, the options of management of their injury or disease, and also need to be informed about the interventions and the consequences of that. For example, yes, you can do surgery, but there's also the idea of not doing surgery. You can get pharmaceutical treatment, you might go for natural therapies, all these kind of things. So the patient then is informed and makes an informed consent, and if they come to our department, of course, they've consented to surgery, and that consent lasts for 365 days, and it should include a consent for blood transfusions, but of course some people, like Jehovah's Witnesses, do opt not to receive anything like that. So once all this consent is established, then the patient can visit the pre-admin clinic. And in the pre-admin clinic, all kinds of tests can be performed. And different staff members from different specialties can look at an optimization plan. For example, physiotherapy is a specialty that can help people to what is called prehabilitate, to get them fit and maybe lose weight before surgery. But also things like anemia and iron need to be tested and so forth. So maybe people need to stop drinking, smoking, all this kind of stuff. So an optimization plan needs to be established and acted upon, and this could take 4 to 6 weeks. And then finally, people arrive at the hospital at the day of surgery, and they will need to have fasted 6 hours of solid, usually light meals, and 2 hours for clear fluids. Then
The day of surgery, the pre-admin staff will perform all the pre-op checks and start the pathways and start the QX chart and get the patient changed in a gown, fit head stockings, um, and also give them a robes usually, and then they go into the first waiting room. Then when the theatres are ready, the pre-op check-in nurses will transfer the patient, do the pre-op checks again, and then wait for either a theatre nurse or an anaesthetic assistant to do the pre-op checks for the third time. Then, if everything is safe, the patient will go to theatre. Usually, we bring a warm blanket and sequential devices. And then we do the surgical safety sign-in. Then, when the um, anesthetic team is ready, they will do a sign-in from the WHO surgical safety checklist. And then, when the patient is ready, they will go to theatre and we do the time out. Then the surgery will take place, and at the end of the surgery, or again, do the third WHO surgical safety check-in process, and it's called the sign-out. The patient is transferred to recovery. The recovery staff will receive a surgical handover and an anesthetic handover, and then look after that patient and work towards discharge criteria. The patient will either go to the ward if they're an inpatient, or to the day unit if they go home. I hope this makes sense. Thanks for your attention.